right. Thank you so much, ComSol, for this invitation and for organizing this event. Very well organized. Congrats on that. So I split my time between treating patients with a cancer therapy called hyperthermia. It's an adjuvant cancer therapy. Basically, it works by increasing the effects of radiation and also chemotherapy. I'll explain that in a moment. And besides treating patients, I also do research, and that's what I'm going to talk about next. Particularly, I develop medical devices for treatment of cancer using hyperthermia devices. So I'll explain a little bit what hyperthermia therapy is, just a status of brain cancer, and then go over to two examples that I've been working on. One is, let me just, all right. One is a non-invasive applicator to treat brain cancer, and the other one is an invasive approach, and I will explain why we still want to do invasive approaches in 2024. I'm going to go over different phantom and experimental models that were created, as well as some experimental testing and also animal testing to validate these approaches. So first, let me just introduce what hyperthermia is. Basically, we want to heat the tumor within 40 to 44 degrees Celsius for 1 hour. It doesn't really matter how we do that. We can use radio frequency waves, microwaves, ultrasound, laser, magnetic nanoparticles. It doesn't matter. As long as we can have the tumor within 40 to 44 degrees Celsius for 1 hour and remain the healthy tissue under 42 degrees Celsius, we are delivering an hyperthermia treatment. It is mostly a chemo and radiosensitizer treatment, so it's not a standalone therapy. There's another therapy called ablation, where we go very high temperatures for short periods of time. That indeed can be a standalone therapy, but this is not the case for hyperthermia. We use it for chemo and radiosensitize. We deliver hyperthermia 2 times a week within roughly 1 hour from the radiation treatment. And the rationale is by increasing temperature, we are also increasing blood perfusion. Well, blood perfusion brings a lot of oxygen into the tumor, and oxygen happens to be a great radiosensitizer. Hyperthermia has also shown to suppress DNA repair mechanisms. So after the radiation, what happens is some of the tumor cells, or they can repair their DNA, and in that case, those tumor cells don't die. Well, hyperthermia is going to suppress that. And then hyperthermia has also been shown to be cytotoxic, particularly above 43 degrees Celsius, within the 43 to 44 degrees Celsius, including cells that are in the S phase. This is a phase of the cell that is very radio resistant. That means cells in this S phase are not going to respond to radiation, and hyperthermia happens to be very effective at killing those cells as well. And then finally, hyperthermia also stimulates tumor-specific immune responses, both locally and systemically. So you can see, there's a plethora of effects by which hyperthermia works. I didn't mention here, but just to have an idea, hyperthermia also works with chemotherapy. If you think about it, because we're heating the area, the blood vessels, they have to open up that way they become more permeable. So as drugs are circulating through the body, in the heated region, the blood vessels, they're more open, they're dilated. That means the permeability increases and the drug leaks more effectively into the tumor. So hyperthermia works both with radiation and with chemotherapy. And the same way it works with standard chemotherapy drugs is also going to work with immunotherapy drugs. So the most common forms of hyperthermia are radiofrequency and microwave. I don't need to tell you this, but just for those who are not very familiar, so microwaves, we're talking about within roughly, for hyperthermia purposes, microwaves, the frequencies we use are 915 in the US and 433 in Europe. So if you look at this plot, we have the relative power deposition on the y-axis versus depth in tissue. So 0 means we are at the skin. And you can see that regardless of the electromagnetic wave, we're going to have maximum energy absorption on the skin. So 915 is typically used for superficial disease. That's because most of the energy is absorbed on the skin. We're talking about the first 3 centimeters. But then if we want to go deeper, we have to go lower in frequency. Of course, that this is only for one source. For deep hyperthermia, we have to use multiple sources. And if we have a high enough number of antennas, we can actually use higher frequencies. I'm going to get back to this in a moment. So there's two heating principles by which hypothermia works, so by which we induce temperature increase using radio frequency or microwave heating principles. One is simply by ionic conduction, so we're talking about resistive losses, and then the other one is the rotational motion of polar molecules, primarily water, which our body has plenty of. So as we propagate the electromagnetic field through the human tissue, it loses its energy, the tissue around it absorbs it, and of course generates heat. The water molecules are going to rotate, and by rotating they're going to create friction, and that friction creates heat. So those are basically the heating principles. And this is truly a multi-physics problem, there go COMSOL, where first we have to solve the electromagnetic field, and from the electromagnetic field we can calculate how much energy is absorbed in tissue. So we calculate the specific absorption rate, which many of you know. It has units of watt per kilogram. This is going to be our heat source, which is going to be coupled to the so-called bioheat transfer equation, which is a module that COMSOL has, which simply expands the standard heat equation. It adds a term for blood perfusion. It's a very important blood perfusion because it's a heat sink. We have an internal heat source, which is metabolism. It's not very important, but then of course the external heat source from the microwave or radio frequency applicator. Now we also have to worry about some fluid dynamics. It's not very important in most cases, but in others we have, like, let's say we're heating a bladder cancer. There's going to be dynamics in the bladder, fluid dynamics in the bladder. We have to account for that. But for the most part, we worry about, or we simulate SAR and then temperature in human tissue. Now, I don't need to tell you how brain cancer is a devastating disease, but let me just put some numbers into perspective. So in the US alone, last year we had nearly 100,000 new cases of brain cancer. A third of those were malignant, and currently we have about 1 million people in the US with brain cancer. 57,000 of those are unfortunately children. And last year, 19,000 people died or lost their battle to brain cancer. So we have to do better than what we are doing now. So if we look at this plot for glioblastoma, and this is one of the most aggressive, if not the most aggressive brain cancer, the current standard of care is about 20% for the 2-year survival. There was a trial that used this drug called telemazamide, or TMZ for short, with radiation that achieved 27%, so not that much better compared to standard of care. Now, there was this trial in '98 that looked at the use of conventional radiation with brachytherapy boost. So brachytherapy is a radiation technique. It basically is invasive, so we have catheters that go into the tumor, so this is pretty invasive, but it has the advantage that it delivers very localized radiation. You know, the radiation therapy, well, the radiation teams, they insert radiation sources into those catheters, they deliver radiation locally, they remove it. It's a very fast, talking about maybe 1 or 2 minutes, and it's a very localized treatment. It's invasive, but it's localized. So they did conventional radiation with brachytherapy, and then they added hypothermia. So using those same catheters, they put interstitial antennas, and they delivered hypothermia. And you can see that by adding hypothermia, it doubled, I repeat, it doubled the 2-year survival. So hypothermia works in brain cancer as well. And again, not again, but we got 31, well, they got 31% 2-year survival, and you can see that it's much better than even the most recent trial that is currently considered the best to date. All right. Let me show you now an example of how we can deliver non-invasively hypothermia to brain tumors. So this design was originated by a company called Parexar Medical. They are the company that delivers hypothermia treatment in the US and across the world. So what I did all the simulations for them. So this device operates at 915. If you remember, I told you we need enough antennas in order to generate a focus at depth. Well, we're going to use 72 antennas. And we also need this water bolus. What it is, it's a water compartment that is placed between the antenna and the human skin. And we use a water bolus for all sorts of external applicators. It has two purposes. One is to make sure that we have enough or optimal transmission of energy between the antenna and the human body. And then the second is to make sure that we cool the superficial skin. Otherwise, we might have some hot spots on the skin. So it serves two important purposes: cooling the superficial tissues and making sure we have optimal matching between the antennas and the human body. And this is truly a multi-physics problem. As I mentioned, we have to use the RF module in order to compute the specific absorption rate. Then we have to use the heat transfer module to get temperature profiles, and then also the CFD module to compute the fluid flow. But we have to be wise about the resources we have. For fluid flow, we actually don't need to solve the full Navier-Stokes equations. So what we do, we simply use, actually that's not true. I did solve the fluid flow. I did use the CFD module in order to estimate, okay, what is going to be the convective coefficient at the boundary of the human head in order so that we don't have to solve the fluid flow every time we have a new patient. So we're just going to use this boundary convective coefficient. Excuse me. Need some water. Convective boundary condition, with a 50 value, and then we also add the water bolus temperature, which is roughly room temperature. Okay, next problem. 72 antennas looks great, but then in practice, are we going to have 72 amplifiers? That's going to be very expensive, if not impractical. So what we decided was, well, we have already a clinically approved device that has 8 amplifiers. Can we use 8 amplifiers to control the 72 antennas? That was the question. So we started simple, as usual. This is a very simple model, cylindrical. It has different, realistically thickness for skin, fat, skull, cerebrospinal fluid, and then brain tissue. And then we determine the phase of the antenna based on, we developed some math in order to calculate the phase of the antenna so we can properly adjust to the focus that we want. And now, just kudos for COMSOL, because this is really easy to implement using the formulas. All right, now what we're looking at here is the SAR pattern. So this is the energy absorption, not temperature. Let's say if we going to consider that every single antenna is controlled independently, we would have 72 independent amplifiers. So this is the pattern we have for different target locations in brain. We have a high degree of steerability. But in practice, we're not going to have 72 amplifiers. What if we have 24? Well, actually, it looks pretty good. It's pretty much the same as 72 independent antennas. But then, if we look on the right, we're going to see that if we use 8 amplifiers, so that means 1 amplifier is going to control 9 antennas, then the SAR pattern doesn't look as great. We still have the hot spot where we want it. You can see, in multiple locations, we are achieving hotspot in the target location, but then we have some off-target hotspots that might be concerning. But this was just an exploration in a very simple cylindrical model. But next step is let's validate our simulation. So we have this setup for the electrical field measurements. We also did some phantom heating experiments where we use catheters to measure temperature internally, so point temperatures, but also we inserted this we placed this phantom into the MR so that we can have 3D thermometry images. And these are the results, experimental results, compared to the simulations, just in the phantom. So we measure the temperature at the center, we increase power for about 3 minutes, and you can see that the simulations match pretty well the temperature at different locations so we measure at the center and then a few centimeters away from the center, and we have a very good correspondence between experiments and simulations. And then we look at the results for the MR thermometry. We have here very nice focus at depth as we planned in as we expected from the simulations. Something that I like in COMSOL is that we can actually customize the color map. Whatever results you have from whatever thermometry device you have, you can adjust the coloring map to adjust your to the experimental values, and that I think has a lot of value, especially for presentations. But bottom line, in this case, we show that we can generate the focus at depth, and then we also show that it corresponds well with the simulations correspond well with the experiments. All right, so this was a simple model. Let's go to a human model. So we use this anatomical human model from NIV Electromagnetics, and then we use the tissue properties from the ITIS Foundation, which is available online. Then we optimize the power in order to achieve maximum temperature of 44 degrees in tumor, minimum of 40 degrees, and then we want to keep the normal temperature under 42 degrees Celsius. And then in the bioheat transfer equation, as I mentioned, blood perfusion is a function of temperature, so we input this blood perfusion scale function so that we can account for that temperature dependence, but instead of doing it explicitly, I just fed it to COMSOL in a table because I found that this is much faster than actually giving the analytical expression. But it's the same expression. And here we have the results for one of the most challenging cases, which is to have the tumor a little bit off-site in both axes. For 72 amplifiers, you can see that we have heating in this area where the tumor is located. For 24 amplifiers, we can start seeing, actually it's very similar, but then for 8 amplifiers, then we have some heating outside the tumor. But again, this white line, this is actually 40 degrees. We're still below 42 degrees in the entire tumor, but we do have some hot spots outside. So maybe 8 amplifiers is not enough. Well, wait a minute. We haven't changed the amplitude at all. This was just changing the phase. So this was just a crude optimization, manual. I haven't done what I learned from this course here. I'm going to apply it and doing this automatically, but I just did this manually. And so the amplifiers close to the tumor, they're going to be at 100%. These two, they're going to be at 50%, and then the other 3 at 33%. Again, this was my first trial, and this is what I got. Before power optimization, you can see some hotspots outside the target location. After this very crude optimization, boom, we clear completely those hotspots outside the target, and there you go. All right, so in conclusions for this first applicator, now we show that we can generate heat focus at depth using this microwave approach. The phantoms, they were reliable in predicting the focus steering. We showed that there is a very good correlation between simulations and experiments. There are some questions about how many channels we need, but it looks like 8 channels might be enough, so we have to do more studies. And the next step is going to be moving towards clinical trial. We just submitted a grant, so we're expecting the results in order to apply this and apply it to patients. All right, let's go to the second applicator, which is an implantable magnetic fluid hyperthermia applicator. So I showed you this plot earlier, and I told you that using interstitial hyperthermia, it doubled the 2-year survival. This is the case if we do hypothermia and radiation sequentially. But if we look at literature, especially only preclinical, we don't have clinical data on this yet, the thermal enhancement ratio is the clinical outcome of the hypothermia and radiation divided by radiation alone. And if we were able to do hypothermia and radiation at the same time, you can see that we would maximize this thermal enhancement ratio. And for higher thermal doses, it could go as high as 5 times. So just to put that into perspective, this trial, if we divide 31 by 15, that's roughly 2. We can maximize that to 5 if we were to able to deliver hypothermia at the same time as radiation. Right now, it's really not possible. So we conceptualized this idea where, all right, let's try to design a balloon. It's going to be an implantable balloon that we're going to place inside the skull. So the idea is there's many tumors that are resectable, so the neurosurgeon goes there, they scoop out the tumor, they close. After 1 month, they deliver radiation and chemotherapy. After 1 month. In that month period, the tumor cells, they migrate and they go away far away, several centimeters into brain tissue, and that becomes really hard because we don't see them, we cannot treat them, and then unfortunately patient dies. If we were to able to hit and deliver radiation right after surgery, that would be optimal. So this balloon is going to go into that resection cavity. So neurosurgeon scoops out the tumor, we place the balloon in, we fill it up with nanoparticles, and then we're going to activate this magnetic field coil, and that magnetic energy is going to be absorbed by the nanoparticles and then released in the form of heat. So we're going to heating the surrounding tissue. At the same time, we're going to insert this radiation source. So this is a brachytherapy approach, where we have this radiation source that goes inside, deliver radiation, we take out the radiation treatment, the radiation source, and continue hypothermia. So the hypothermia, remember, it's 1 hour. In the middle of the hypothermia treatment, we deliver radiation, which is just a few minutes. So that's the idea. So in COMSOL, I use the design module in order to create this phantom structure. We then 3D printed and filled it up with a gel that has properties of human brain. Here's our balloon filled with nanoparticles. You can see it's black. And then we use a thermal mapping, which is essentially just having a mechanical motion. There's a temperature probe right there, and we just move it back and forth. So we did a mapping. And then we also measure the temperature at a certain distance from the balloon. And then you can see here the magnetic field coil and the specs for this magnetic field coil. All right, these are the results just for of one of the experiments. We increased the power, and as you can see, as we increase the power, temperature in the nanofluid it went up by about 12 degrees Celsius, and then this temperature is going back and forth. This is the thermal mapping. Again, this is the temperature. It starts here in the middle, so it's maximum. So we just move it back and forth. And by doing that, you can see the temperature goes down. So we're moving away from the center of the balloon, where it's hottest, and then we go at the center of the balloon. And then these two are stationary probes, roughly at 9 and 13 millimeters. Did the exact same thing, but instead of simulating the thermal mapping, I just capture the temperature adjacent to the balloon, that is maximum. You can see that here in green. And then these are the experimental results. And again, we have a very good correlation between experiments and simulations. Same thing here, I'm comparing experiments and simulations, but in this case, I took a 2D, a thermal image. And you can see the thermal image here in the left and the simulation on the right, and we have a very good correlation between those two as well. And then, okay, this is all good, but just one experiment? No, we actually did 4 balloons. Each balloon has 2 thermal maps. We have the range of temperatures here in gray, and then in yellow we have the temperature simulation, and you can see, very excellent match between our experiments and simulations, thus validating the COMSOL simulation. Sorry for the gross image, but we also did animal experiments. In this case, in humans, we want to use anywhere between 2 to 5 centimeters balloons, but in pigs, we had to go with 1 centimeter because the skull is really small. Then I did this very simple model of brain and skull. It has fairly accurate dimensions, but of course, it's a simplified model, but we don't really care about what happens many centimeters away, so, having the exact skull shape wouldn't really matter. Then we position the catheters in this model like we did in the experiments. And then we assign a temperature-dependent blood perfusion model into the bioheat transfer equation. And we got this model from experimental data published from literature. These are the results for 3 pigs. You can see that there's a wide range of temperatures. And the reason is, the neurosurgeon, took some time to get trained to position the catheter. So the first experiment, we were pretty far away from the tumor, but then the last 2 experiments, we actually got very good. We were able to position the catheters closer to the balloon to capture those heating profiles. And then I simulated the temperature range of the expected location of the range of expected location of the catheters, and then I plotted the average against the experiment, and you can see an amazing match. So this also validates COMSOL simulations and the module we developed for living animals. So we showed good correlation between experiments and simulations. We showed symmetrical heating, which is very important because we want to make sure that the heating around the balloon is homogeneous. And then the other thing that I'm going to highlight, and this is a request for COMSOL, which is I spend a lot of time with creating models, anatomical models of human patients or animals, and something that I would really be happy to have in COMSOL would be a tool to do segmentation. And if you guys can pull this off, this will explode in medical field, because we really need to do patient-specific treatment planning. And I truly believe that, especially with your compiler, this is going to be the basis for a future treatment planning approach in radiation oncology clinics. So with that, I end the presentation, and I thank you so much for your attention.